think it's recording now. Or wait.
Oh yeah.
Now we're live.
Wonderful.
Just wait for some more people to join in.
Yeah, and then we can get started.
I'm still here, just kind of so I'm not when I mute myself, but don't worry.
No problem.
I'll sneak off like 5 minutes after you start.
Sounds good. Do people tend to start at 7-ish on the dot?
7-ish, 7:02, something like that.
7:02. Gorgeous.
It depends on you. All right, good luck.
Thanks. I'll wait a couple of minutes, then I'll get started.
All right.
Thanks so much for coming, everyone. We'll just wait a couple of minutes for people to join. All right, it's just gone 7, so I think we should just get started. First of all, thank you all very much for coming to the talk. I've been told that there's a football game on, so I appreciate it even more that you're all here listening to my talk on essential tips for your surgical job in F1. So let's get started. So a little bit about me. I started F1 last August up in the Northern Deanery, and I've had 2 surgical jobs so far in F1. The first of which was upper GI surgery with general surgery on calls. So that was covering colorectal, breast and endocrine, as well as upper GI on nights and weekends. And I'm currently on urology as my 3rd job of F1. So 2 surgical jobs, but I've actually got no desire whatsoever to be a surgeon. So I thought I'd bring a different perspective maybe. But what I have done is spoken to lots of friends and colleagues who do want to be surgeons to get some top tips for you all on how to get to theatres and maximise your time in surgery during your rotation. So the learning objectives that I've got down for today. So we thought we'd start by going through what a normal day looks like on a surgical job. And then we'll move on to how to get into theatres, tips and tricks, and how to plan things like that. The next section will be all about surgical on-calls and nights, things that you might get called or bleeped about overnight on those shifts, including temperature spikes, fluid prescribing, and managing post-op pain and nausea. The last section is all about emergencies. So we're going to be covering sepsis, major hemorrhage, and opiate toxicity, which I think are the things that people are sometimes most apprehensive about dealing with. And we'll end on some top tips just generally for a surgical job. It's also worth saying what we won't be covering on this talk, and that's surgical presentations, things like how to diagnose appendicitis or cholecystitis. As an F1 on surgery, you'll generally be on ward cover rather than clerking in new admissions and going down to A&E and seeing patients. That's usually the SHO and Reg job. And you would have had lots of teaching on appendicitis and cholecystitis at med schools. So that's what we'll not be covering. Is there anything at all that anyone would like to cover other than that? If you just pop it in the chat. I can't see anything in there. And I will also say there's some interactive little bits of audience participation throughout this talk, and it would be just great if you can pop things in the chat. No answer is a silly answer. Like, just have a go, genuinely, and it makes it much more fun and less embarrassing for me as well. Fab. So let's get started. So what does a normal day look like on surgery? Surgical days often start quite early, as you'll maybe know from your med school placements. So they often start at about 8 o'clock. But what I'd recommend is just arriving a few minutes early so you can get changed into your scrubs. And a lot of surgical departments will have a list of patients stored as a Word or an Excel document on a shared drive. And as the F1, it's generally your responsibility to make sure that's printed for the morning ward round if your department happens to have one of these lists. It's often one of those things that the SHOs and registrars just really, really want you to keep up to date. That's useful for them, but also for you and your F1 colleagues. So it helps with effective handover. The next part of the day is the ward round. That's often really quite rapid, from about 8 till 9 o'clock in the morning, before everyone goes off for theatre briefing. And that means that because it's so speedy, you've got to obviously be trying to get on top of things. And I found we have electronic records. We're lucky enough to have that. And keyboard shortcuts are the first thing that I'd recommend just setting up early on in your surgical job, so that when you're typing, for example, at ward round, you immediately get your lovely ward round template that you can just fill in for each patient. For paper notes, I suppose my big tip would be just getting down the key points, and I'm sure, yeah, that's all that you'd be expected to do rather than writing quite long essay type things. So the main thing is just getting down your plan. So this is the structure of my little ward round template that I've got. So it starts off with the ward round, and then I write down the name of the reg or the consultant who is leading that ward round. Surgical ward rounds are almost always led by a consultant or a registrar. They're very senior led. So it's important you put the name of that person down so you know whose plan this is when you look back in the notes. And I follow that with a little patient summary to date, including any operations they've had, any complications from those operations, and dates of those things too. The next thing to look at is the most recent set of observations for that patient, as well as their observations over the last 24 hours. So what's their most recent news score? So for example, news 2, and the surgeons will be interested in whether they've had any temperatures during the last 24 hours to 48 hours. I would then look at bloods. The things which the surgeons will be most interested in are the CRP and the white cell count, as well as sometimes the hemoglobin as well. But as the F1, just have a look at all the bloods that were done over the last couple of days, any electrolyte abnormalities that you need to correct, anything else that jumps out at you should be written down in the ward round and discussed. The next part is any investigations, any recent scans. That doesn't mean every chest x-ray they've had over the last month if they've been in, but just anything that's really changed the management of that patient. For example, a really key CT scan that's shown a complication, for example. And then the next two bits are what's happening right now. So what the review is, so writing patient sat up in bed, looks comfortable, and then anything the surgeon's saying to them. And the most key part of your ward round documentation is actually the plan right at the end. So because the ward rounds are rapid, your main goal is to just get down the plan, really. After 9 a.m, you can always go back, you can fill out the rest, but getting down a plan is really, really crucial, as often the seniors will pop off to theatres, and you can always obviously ring them to clarify anything, and most people will be absolutely fine with that. But it's just easier if you've got your plan for management written down early on. Fab. So after your ward round, you'll hopefully have a bit of a moment to grab a coffee, and then prioritise your jobs. So I'd really recommend having a good organised jobs list for each patient that you've got. Surgical wards are often big. There's a lot of patients that you'll be looking after, and just knowing if you need any discharge summaries doing for a patient, any urgent jobs, it just makes it all a little bit easier. So the way I would prioritise my jobs is, first off, any sick patients. Sounds obvious, but anyone who's unwell, that goes top of your priority list. Followed by ordering and discussing any urgent scans with radiology, especially if you want them to happen on that day. Doing any prescribing tasks at all, and taking any bloods that are not already done by your lovely friendly phlebotomists on the ward. And that's really important to do before late morning, really, so that you've got the results back before you leave and you don't have to hand over all of the bloods to the evening team. You'll often be liaising with other specialties on surgery, most commonly, as mentioned briefly, radiology to get scans done, or to ask for advice on a scan that's already been done and its interpretation. And you'll also be ringing microbiology a fair few times for advice on antibiotics. And then your sort of afternoon part of the day is often reviewing any of the results from scans that have been done, any blood results from bloods that have been done, and if appropriate, discussing those with seniors. And peppered throughout your day will be requests for updates of families of patients who are on your ward. And that can be a really nice way to feel really engaged with patient care, because as you can see from the list above, other than reviewing sick patients, a lot of it's actually quite detached from the patient itself. So I think it makes it, you feel a lot closer to patient care by doing the family updates. It can be really rewarding. From a wellbeing perspective, definitely take your breaks. It's a big long list of things to do, but it's really important to just take 30 minutes at lunchtime, go and eat your sandwich away from the ward, and let the nursing staff know that you're doing that, so you're not getting bleep for anything other than reviewing a sick patient, really. And before you leave, I would always say just ask yourself 3 questions. Is your list up to date, if you have a list, that is, as that'll be really useful for you or whoever is going to be printing that the next morning. Are the bloods out for the phlebotomists for tomorrow? In most hospitals, there's a system of having a list of patients for the phlebotomist to take blood from the next morning. For example, in our hospital, if you don't make that request on the electronic system the night before, it probably won't get done in the morning. So making sure all your bloods are out is going to make sure that you have a bit of an easier day the next day. And then finally, and most crucially, do you have anything to hand over? Do you have any results to hand over? Do you have any sick patients to hand over at the end of your day to the on-call team? So as promised, I thought I'd add in a little bit of advice on how to get to theatres. Now, obviously, everything we've just been speaking about, it sounds quite busy. There's a lot going on. And so it is true that getting to theatres can be tricky when you're on minimum staffing, if you're on a really busy ward. So from speaking to friends who want to be surgeons, these are sort of the top tips. And firstly, just plan ahead and be organised. So look at the week ahead and see when you've got more staff in your rota, more F1s present on the ward. And for example, on say Thursday afternoon, you've got 4 F1s and your minimum staffing is usually 2 F1s. So you've got a few more people around. And so you also see that there's a theatre list that you'd quite like to get to on Thursday afternoon. So contacting the consultant early on can be really useful in terms of making sure they're expecting you and they're okay with you coming along. Equally, as well as it's all well and good to plan ahead and be organised, but it's also important to be proactive and flexible because opportunities will just arise. I remember one afternoon when I was on upper GI surgery, they needed someone to assist in a thyroidectomy in endocrine, and they just rang up the general surgery F1 phone and said, "We need one of you to come up to theatres in half an hour." And that was very spur of the moment. It was really enjoyable to just get to go to theatres for about an hour or so. And so just making sure that you're flexible and you take opportunities where they come as well. Communicate well with your colleagues to make sure that while you're away from the ward jobs are getting done. So either that means making sure they're done in the morning and then going off to theatres in the afternoon, letting your colleagues know that you're where you are and whether you'll have a bleep on you, whether you can come back to the ward if it gets really busy, and also just communicating with colleagues because you might have several people who are interested in going to theatres. So just be considerate and take turns, basically. If you're starting on surgery, your clinical supervisor and your educational supervisor will likely be a surgeon. Now, we've got portfolio talks from Mind the Bleep coming up, which will explain those a little bit better, those terms, but they essentially are just in charge of supervising you as an F1. And they can be a good person to just go to right at the beginning of the rotation and say, look, I'm interested in surgery. I want to get to theatres. How do I do that in this hospital? What would you recommend? Who's best to be in theatres with, for example, as well? Who will actually let me get hands-on and involved? So a lot of my friends who want to be surgeons definitely say that as well, that they flagged it up early on to their ES and CS. And then finally, as an F1 and F2, you have something called self-development time or SDT time, which is 4 days per rotation, or it might be given to you in hours off your normal days. And you can use that time to essentially do anything that will further your learning, so projects and audits and things like that, but also going to theatres. And a number of people would say, you know what, you going to theatres is very good use of your time if you want to be a surgeon for that. Okay, so I hope that helps. Any questions at all about that? I think I can see the chat. Fab. Okay, so let's move on to on-call shifts. So an on-call shift starts with a handover. And at handover, you want your little bit of paper and a pen always, and you'll be noting down any jobs or results that are pending from the day and any timings of those jobs if relevant. The one that sprung to mind to me when I was making this presentation was doing an anti-10A blood test, which needs to be taken 4 hours after someone's had a low molecular weight heparin, to see if it's working as anticoagulation. And so that's a useful thing to just jot down as well, that this blood test needs to be taken at 10 p.m, for example. I usually also have a separate list of patients to be aware of. Those are patients who are sick, usually, patients who you'll probably be called about anyway. And so it's just good to have an idea if there is a management plan there at all already before you go and see that patient. And then once you've got your list of jobs and handed over, the next thing to do is agree which jobs each member of your team will do. One example is, for example, if you've got a very sick patient who may need to go to theatres overnight and be consented for that, it's probably worth the reg going and seeing that patient as opposed to you as the F1. And so just flagging that up to the registrar early on can be useful there. And prioritisation wise, works just the same as a normal day. So sick patients come first, any prescribing and other jobs come a bit later. My little top tip for a surgical on call and how to manage the first couple of hours is you'll get lots and lots of calls from wards, and that can sometimes interfere with you actually getting the jobs done in a way, because you get interrupted by calls and it can be a bit overwhelming when you first start out. So my little top tip is, say ward 42, a surgical ward, rings you at the beginning of the night about a patient who needs IV fluids prescribing. And while you're on the phone, you might say to the nurse on the phone, do you have any other jobs for any of the other patients you're looking after at all that you can just flag up now itself that you know are going to get done, have to be done during the night, like a cannula, for example. And then I would often say, and could you ask the nurse who's looking after the other side of the ward whether they have any routine jobs? And that means that by the first couple of hours, you've got a list of routine jobs, more routine jobs that need doing. And thereafter, you're only really going to get called if someone's sick. And that really helped me, especially on my general surgery on calls overnight, just with stopping my bleep from going off all the time and instead being able to focus on what I was doing. Okay, so time for a little bit of audience participation. So it's 10 p.m. on your night shift, and you're called about a 50-year-old lady who's day 3 post left laparoscopic donor nephrectomy. So she's had a kidney out to donate to, say, her spouse, and you've been asked to see her because she's got a temperature of 38.2. So what else do you want to know? If you just pop things in the chat. So you're on the phone. What else are you going to be asking? Yeah, absolutely. Any obs other than that? Anything else that you might ask? Yeah, so definitely other obs. And those are her other obs. So her blood pressure looks all right, and so does her heart rate, but her respirate is a bit up, and her SATs are a bit low, to be honest, and she's needing some oxygen there as well. I often also ask, oh, have you given some paracetamol if they've got a temperature? And they've said, yeah, they're giving some oral paracetamol now. And then another good thing, just especially when you're just starting out, is to ask is, are you worried about this patient? Like, how worried are you? And the nurse says, oh, she looks all right, but she does look a bit flushed and breathless. So this lady needs a review, clearly. So on review, you go through your A to E approach, and you do a full systems review as part of your history too. And you've done that really well. So on your main findings, you find out that she's been coughing up yellow sputum, she's been more breathless over the last 24 hours. She's got left basal crackles and auscultation, and she's in some abdominal discomfort. But when you do examine her abdomen's nice and soft. There's no real tenderness to palpation, and she's got good bowel sounds that are active. So what are your next steps? Again, just pop things in the chat. And as I say, like, just have a go, even if you don't know. Yeah, absolutely. Absolutely. Definitely needs a chest x-ray. Yeah, bloods and a chest x-ray, great. Yeah, bloods definitely, FBC, CRP, chest x-ray coming up again. Absolutely. All those things. That's really good. It's nice to see stuff in the chat. That's great. So yes, you've done your bloods. You've also been really good and you've popped on a VBG as well, because you might as well while you're doing the bloods, to be honest. Her white cells are up, driven by neutrophils. Absolutely. I've just seen blood cultures pop up. Yeah, definitely blood cultures as well. Her CRP is also raised. Now, a post-op rise in CRP is generally quite normal. Her previous CRP was 102 on the first day post-op. It's shot up a bit to 205 today. And on her VBG, her lactate's 1.2. You've taken some blood cultures, and for good measure, she's not mentioned any urinary symptoms, but she's had a kidney out in the urinary tract. So you do a urine dip, and you send off the urine for culture, and the urine dip hasn't really shown anything. And as most of you have said, a chest x-ray, you've ordered one of those too. So my top tip here is just have a really low threshold for ordering these investigations. So in your head, when you see someone with a temperature, just think bloods and a VBG, blood cultures, urine dip and culture, and a chest x-ray, as what we'd call like a septic screen almost, to see if there's anything brewing. Fab. So as many of you said, you've done a chest x-ray, and how would you describe what you can see? The big red ring does make it a little bit more obvious, I will say. Yeah. Oh, I've got a question coming up. So at what stage of reviewing this patient would you inform the reg? That's a really, really good question. So obviously, if you're worried about someone and they're unstable, definitely you'd be ringing your reg at that point. Yeah, lower left hand consolidation, that's great. But yeah, I think in this case, she's relatively stable. I would get your investigations and then ring up a senior after that and just say, just to let you know, I've seen this patient, I've done these investigations, she's got left lower zone consolidation and pneumonia, as you've all rightly said in there. And this is the case, I'm doing my management plan, which we'll talk about just after this. Is there anything else you'd like to add? Fab. So does that answer your question, Armin? But yeah, fab. So you've all got it absolutely bang on. So the red ring definitely did help on here. So yeah, left lower zone consolidation is a likely chest source of infection here. And oh God, that was a bit of a giveaway, but what's your management, do you think? A few little bits. You might have just seen it when it popped up. Right. Yeah, so your management plan, antibiotics. Yeah, absolutely, antibiotics. I've just seen it pop up there. And it would be according to whatever your trust protocol is for a hospital-acquired infection, because she's been in for 3 days now. Chest physio is actually really, really important. Something that I've realised as I've gone through F1. So post-operatively, patients are often quite immobile. They're in a lot of abdominal pain if they've had abdominal surgery, and that means they're not breathing in really at all very deeply, and that makes them so prone to getting chest infections. So getting them some chest physio so that they're clearing up their mucus, they're coughing well, that is really good. Making sure they've got adequate pain relief as well, so that they're able to breathe deeply, is a good prophylactic way of making sure people don't get chest infections like this. Get them up on their feet and mobilizing, and monitor the obs for any deterioration. So if they're needing more and more oxygen, if they become septic, then that would be obviously a red flag. So helping nurse to know this is someone just to keep an eye on overnight. So that brings me on to talking about post-op complications. So the way I like to think about this is as a timeline of how many days post-operatively someone is. So we've seen an example of a respiratory source of infection there, and that can happen from day 1 to day 2 really onwards. A temp spike that's just one-off right after surgery, day 1 after surgery, that can actually be a normal response of the body. It's been through a big insult and it's a big inflammatory response that might cause a temperature. So it can be normal to just have one temperature after a surgery. Still warrants a review to make sure there's not obviously something else going on as well. But if you don't find anything, that's probably one where call up your SHO and say, oh, I haven't found any source of infection. What do you think we should do? And they might just say, you know what, it's just a one-off response to surgery, no problem. They're otherwise very well. Directly after an operation, that's also when the risk of strokes and MIs goes up quite a bit. So anyone complaining of weakness, slurred speech, any visual changes, any chest pain, it sounds obvious, but just make sure you're reviewing them ASAP, basically, as it does happen, and it does happen commonly on a surgical ward that people will have a heart attack or something after an operation. Okay, so moving on to day 3 to 5. So this is when a lot of complications start to show themselves. Respiratory source we've already spoken about, but also urinary source of infection. I'm on urology at the moment, and it does happen sort of day 3 to 5. This is also when the risk of blood clots becomes higher as people are immobile after surgery. So that's definitely something to bear in mind. And also serious complications when patients have had anastomoses, like anastomotic leaks, for example. And you've obviously still got that risk of stroke and MI that's increased post-op. I always think day 5 to 7, that's when sort of the more surgical site things start to happen. So around the actual area of the operation itself. So that's when you get wound infections, abscesses and collections. You've still got this high risk of blood clots because people are sometimes still quite immobile. That's why it's important to get people mobilizing after an operation as soon as you can. And the risk of stroke in MI is also quite high still. Okay, and then after day 7, things start to get a little bit hazier. So you can obviously get any of these things from day 1 to 7 after day 7 as well. It's the human body, it's difficult to predict in that sense and say you absolutely won't get a chest infection after day 7. But that's when you might start thinking about drug reactions. For example, if you've started an antibiotic for a chest infection and the day after they've started to become more unwell, you might think about that as a cause. Wound dehiscence also occurs after day 7, which is something we'll talk about a bit later in this talk. And I've sort of done it as a flowchart like this, but some people use the mnemonic of wind, water, walking, wound, and wonder about drugs, which is essentially the same thing. So wind, respiratory, water, urine, walking, they're not walking. So venous thromboembolism, wound, site infections, and then wondering about basically everything else that might be causing someone to be unwell. So whichever way you like to remember it, it's just good to have a bit of a framework in your head. So a little summary of how to manage post-op pyrexia. So make sure they've been given some paracetamol, as it'll make them more comfortable by the time you do turn up to review them. Always just stick with your A to E approach and always consider sepsis as well. A one-off temp spike post-op can be normal. It still does warrant a review. So don't be sort of just dismiss it as normal. Still go, take your bloods and cultures, see if it shows anything. And as I say, have a really low threshold for just doing some basic investigations if someone has a temperature on the ward. Common things are common. So respiratory, urine and wound are all really common. And you'll become very, very familiar by the end of your surgical job about the local guidelines and your trust for antibiotic advice for those particular infections. And when in doubt, as someone mentioned in the chat earlier, just call your SHO or Reg for help. And we'll be speaking about this a bit later on as well. Okay, so we mentioned venous thromboembolism. It can be associated with the low-grade fever, sort of 37.8, 37.9. And you'll assess based on your A to E. So DVT, you might find calf swelling, erythema, tenderness and warmth. In my experience, it's usually just the calf swelling and tenderness that gives it away. You don't always have the erythema associated with it. And your textbooks will say calculate your Wells score. Now, the problem is that a D-dimer is often raised post-operatively anyway. So a lot of patients, when you do suspect a DVT, you might just go for an ultrasound scan anyway. Now, if you do have a confirmed DVT on that, before you start any anticoagulation surgery, discuss it with the reg, a senior surgeon, as obviously it's all a balance of you don't want someone bleeding intra-abdominally from anticoagulation given for a DVT. So it's that risk and benefit, and we're not expected to make those sort of calls as an F1 there. A PE, so the things you might find on your A to E assessment are an increased oxygen requirement, you might have an increased rest rate, they might complain of some pain as they're breathing in, which is pleuritic. Again, a D-dimer, if they've just had an operation, it can be less helpful here. So discuss it with a senior, and they might just tell you, you know what, just get a CTPA instead. Even if their Wells score is lower. So you might just progress straight to that. You'll also be just getting a chest x-ray and an ABG if they've got some increased oxygen requirement as well. And again, if there's a confirmed PE, make sure a senior knows, because you'll be thinking about starting anticoagulation. So that needs to be discussed with someone. Fab. So to stop us from getting into that sleep in the first place, all patients should have a VTE risk assessment done on admission. Surgical wards are some of the most hot on this that you'll get. Everyone needs to have this done, basically. And local hospital policies are different, but they are usually a mechanical form of prophylaxis and a pharmacological prophylaxis that's usually a low molecular weight heparin. That'll be different based on which trust you're working in, which is something I didn't know before I started. I think the trust where I was a medical student, it was enoxaparin that everyone got, but in my trust currently it's tinzaparin. Just make sure you know that before you start, or just like as you start on your first day, what VTE prophylaxis it is to prescribe, and there's usually a really good guideline about it. So yeah, mechanical prophylaxis is TED stockings. There are some contraindications just to be aware of in the back of your mind, but if they've not got any of these, they really do need to be wearing their TEDs on the ward. And you'd be surprised how many people actually don't, when they're not very comfortable to wear, if anyone ever has tried them on. And then your low molecular weight heparin prophylaxis. So that's all very much a risk sort of benefit balance to get right. And it's important that you have in the back of your head that there's a caution renal impairment as well. So that's when you're picking up the phone, speaking to your friendly pharmacist on the end of the phone and asking for a bit of advice. And they might suggest dose modification or another agent if they are in really severe renal failure. The most important thing I think about VTE prophylaxis is this third point here, consulting the op note for the post-op plan. So surgeons are very good at documenting usually when they want prophylaxis to start. So that might be the night of the surgery, so right after the operation, or it might be the next day, it might be the next morning. Just make sure you've looked at the op note so you know when to prescribe it for. You're not giving them their low molecular weight heparin too early or too late. And it's also worth bearing in mind it's dosed based on weight. And so again, just have a look at the trust guideline. It usually tells you for which weight bands, what dosages you're prescribing. Right, any questions at all about VTE? I'll move on then to wounds. So as we discussed earlier, wound complications are generally day 5 and later. And wound infections are some of just the most common complications that you'll see. Usually present within about a week with fairly obvious things like pain at the actual operation site, discharge, really bad redness and swelling around the wound. The first thing to do would be to take a wound swab, make sure that is taken, and then treat with antibiotics as per your hospital protocol for a skin or soft tissue infection. Once your wound swab results are back, you can obviously then modify what antibiotics you're giving. Wound dehiscence, if you haven't seen it yet as a medical student, you almost certainly will see it on your surgical job, and it's not something that you'd really forget. It's when the wound opens up, most commonly after an abdominal surgery, and that can open up in a superficial sense with just the skin part of the wound opening, and that is just managed with simple wound care. It can be really distressing for the patient though, because it looks quite scary to them, but you can just reassure them and say, look, this is something that we just manage with dressings and regularly changing the dressing and packing in your wound. However, if there's any suspicion at all that this is a full thickness wound dehiscence, where you get burst abdomen appearance and abdominal contents leaking out, that's caused by the rectus sheath failing to heal. That's something where that's an immediate escalation to a senior. They might need to go back to theatre urgently, and they'll probably need some broad spectrum antibiotic coverage, but you'll be discussing that with a senior, I'm sure. So some of the risk factors for wound dehiscence happening can be related to the patient themselves and their medical history. So smoking, diabetes, obesity, they all increase the risk of wound dehiscence after an operation. Operation factors themselves, so someone who's been rushed to theatre for a really long operation at night is more at risk than an elective patient who's been planned months in advance to have their gallbladder out. And then also post-operative factors such as prolonged hypoperfusion of the tissues. So if they've been hypotensive post-op for a while, that can also increase the risk of wound dehiscence. Fab. So your next call of the night is for fluid prescribing. So you get a call saying, hi doctor, would you be able to prescribe some fluids for this patient, please? What questions do you think you might ask over the phone? I can't see anything in the chat so far, so I'm just going to plod on this. So the first thing to know, and the most important thing, is the indication. So is this fluids for resuscitation? Is it fluids for maintenance? Or is it fluids for replacement? So yeah, absolutely. I've just seen some people's pop up, absolutely there. And yes, any comorbidities, heart failure, well done. That's really good to know. And what fluids they've already had as well to add on top of that over the last 24 hours. So the indication is the most important. Also find out if they've got these comorbidities. Okay, so resuscitation fluids. These are for a shocked patient whose blood pressure is low, tachycardic. You'd be doing an A to E approach to review and treating the cause, not just giving fluids. I'm sure, as you'll know, it'll be a 500 ml bolus over a really short amount of time of sodium chloride or Hartmann's. And I think the most important thing, which I'd say, is make sure they're rechecking the blood pressure after the bolus is given. You'd be surprised how many times it's not checked, actually. As we mentioned in the chat, absolutely, if they're heart failure or renal failure, if they're elderly or have a low body weight, you'd definitely be thinking more along the lines of a 250 ml bolus. If their blood pressure is still low after rechecking the blood pressure, after that, but first bolus, consider a further one. But if you're giving more than 2 boluses, or there's an element of fluid overload to the patient, they do require senior input. So ringing for advice is not at all a bad thing in those situations. You'll probably need some advice on what you're doing. Another thing which I think often gets missed out is to consider whether someone actually needs maintenance fluids after their bolus. So if on your A to E approach you found that they're actually quite dry, they're not really drinking anything, they might just need some background fluids as well. So that brings me nicely on to maintenance fluids. So what's the indication? Are they nil by mouth for surgery or bowel obstruction, for example? And you would genuinely be surprised how many times you're just asked to prescribe fluids for someone who is on a normal diet, eating and drinking absolutely fine. And they don't need fluids. Like, we don't drink overnight normally. And so patients don't routinely need fluids overnight unless there's a real reason for it. Check their bloods. Are they depleting any electrolytes? And are they hypovolemic? Do they need a resuscitation bolus really first? In terms of maintenance, those are the values that you can see up on the screen in terms of daily requirements of a person for in a bag of IVT, basically. And 5% glucose contains 5 grams per 100 mils. Hartmann's and sodium chloride contain quite a lot of sodium, which is something that a lot of people don't know. So we're usually actually giving people way too much sodium. Usually not a problem, kidneys will filter it out, but we're not giving them enough potassium or glucose, and there's no protein or fat in fluids. Sounds quite obvious. So if someone needs maintenance for longer than about a couple of days, you should be speaking to a dietitian really, as they're not really meeting any of their dietary requirements. So bearing all that in mind, I thought we'd go for a little example. So grab a bit of paper and a pen and a calculator and see if we can do this one together. So you've got a 53-year-old lady who's 80 kilograms. She's got no comorbidities. She's nil by mouth because she's got small bowel obstruction and she needs some maintenance fluids for the next 24 hours. Her electrolytes are all normal, but she's a little bit hypovolemic. What might you do? Just pop something in the chat. So I might just go back to this slide as well, just so you can see the daily requirements and the numbers. 2. Is anyone going to be brave and pop something in the chat for what their fluid prescription might be? Just in the interest of time, I might just plod on here. But this is what an example is. Everyone might do it differently, but this is what I got out of it. So those are their daily requirements. And so the fluid prescription that I might go for is 2 1-litre bags of dextrose with potassium chloride already added into it, and then a litre of sodium chloride as well. And you can prescribe those over 8, 10 hours, whatever, probably 8 hours there, so then you get that 24 hours. One thing you'll hear is 1 salty, 2 sweet, as a sort of guideline. So 2 sweet bags, 1 salty bag. That can be a rough guide, but just don't forget the other electrolytes as well there. Okay, and the final thing is replacement fluids. So replacement fluids, it's just basically you have to realise that you can replace electrolytes orally as well and take that into account, and take into account any sort of edema factors like that as well. And if I can signpost you to one thing to look at after this talk, it would be this nice guideline on IV fluid therapy. It's got a really good flow chart that, especially when you're just starting out, it's really just useful to have on your phone downloaded. Fab. So your next call is for analgesia. So can you prescribe some pain relief for patient Y? They're complaining of pain after the operation yesterday. So what are you going to ask over the phone? What do you want to know? Yeah, absolutely. Have you given them anything? When? Yeah, perfect. What have they already got on there? Yeah, what have they had? Are their PRNs prescribed? Perfect. Well done, guys. So yeah, the first thing I probably think is this somebody, yeah, allergies, absolutely. Is this someone you need to review? So if they got sudden onset, worsening pain after an operation, what other observations? Is the nurse concerned? Like, do they actually need to be seen by somebody here? Either way, they're going to need some pain relief. So absolutely, what have they had already? What route? Any allergies? Definitely look at what's their renal function or hepatic function like, and also their weight, which obviously for paracetamol is important, but also for other painkillers. It's also a note that if they're on patient-controlled analgesia, where they press a button for fentanyl or morphine, as an F1, just don't prescribe, just don't touch anything in terms of opioids. On top of that, it's usually just not allowed in a trust to prescribe an opioid on top of that. So in our trust, what we do is we call anaesthetics for a review of the PCA. So just prescribe some paracetamol and get them a review from anaesthetics. And this is the analgesic ladder, which I'm sure you would have seen before. Something that I would definitely recommend is obviously when you're prescribing an opioid, start low, go slow as you're increasing, and make sure you're checking their renal function. So oxycodone rather than morphine if there's impaired renal function. And the other thing is to make sure you're prescribing a laxative along with any opioids as well. So something like Docusate, for example, can be really good for that. Yeah. So moving on to nausea and vomiting. So when you're called about someone who's got nausea and vomiting, consider if there's any red flags first. Is it feculent? Has there blood in it? Are they shocked in terms of their OBS? Are they vomiting large volumes, so they're losing electrolytes? And they're probably going to need more than just an antiemetic prescribing in any of those cases. And these are the three antiemetics that you'll probably be prescribing most on surgery: ondansetron, cyclizine, and metoclopramide. In the interest of time, I'll let you have a little read quickly of that. But yeah, there are some cautions for those. Definitely cyclizine in particular can make people confused. It can also be a drug of abuse as well, just something to bear in mind in your head. And metoclopramide, the big no-no, is bowel obstruction. If they're vomiting lots, consider the IV route. So what else might you be called about? So this is just a list of other things that I've been called about on my weekend on call that I've just done. So these things are also on a medical ward. So anything that you can be called about on a medical ward can also happen on a surgical ward too. And we've got some great talks from Mind the Bleep coming up. I think the first one's on the 10th of July, which is like an asked to see patient medical on calls talk, where they'll be covering all of these things in a lot more detail. I thought I'd have a quick slide on practical skills, as I think that's something that I was definitely a bit worried about when I first started F1. I don't want any of you to be worried about, basically. So the first one is cannulas, which I think a lot of people get hung up on. And the first thing when you're asked to do a cannula is why and when do they need it for? So if the antibiotics are only due at 6 a.m., that can go further down your list of jobs you you don't want to be waking up the patient at 2 a.m. to do the cannula for their antibiotics at 6. Just do it at 5:30 maybe. Instead, it's a bit more of a decent time for the patient. You'll get a lot of practice on surgery doing them. And something I wish someone had told me before I started F1 is that you will just have good days and bad days with them. And you'll have good weeks and bad weeks. So don't get disheartened if you've had a run of cannulas that you haven't been managed to get, even though they've got perfectly good veins. It happens to literally everyone that I know, and it's not something to worry about at all. If someone is needing IV medication for over a week, or multiple drugs given IV with difficult access, start considering whether they need a midline or a PICC line inserted early on. And with cannulas, just if you've had 3 goes at it, escalate it. There's no point in you just stabbing the patient over and over again. It just needs to be escalated to someone else, really. And a lot of trusts now have the opportunity for you to learn how to use ultrasound to do cannulas, which is super useful. So definitely sign up for those if you can. I know some medical schools already teach that, which is fab. So bloods wise, I think my main message here is to make use of other people who can do bloods. So phlebotomists, some nurses can do bloods, some HCAs can do bloods. So ask other people for help, because this is something that if you're doing like 10 bloods, that actually does take up quite a bit of your day. You can use ultrasound to do them. And my top tip for difficult veins for bloods is you can use the tiniest little butterfly and connect it up to a little 5 ml syringe, and it just puts a bit less pressure on the veins. And I think from my experience, you get a better success rate with someone with difficult veins. And whenever you're taking bloods, just keep track so you know how to chase the results. And I'm currently on urology, so of course I'm going to talk about catheters. And the main message here is who has tried to do it. Most nursing staff will be signed off to do male and female catheters, and they should have had a go, really, as you'll be covering multiple wards on call. When to put one in, if they're in retention, so over 500 mils in a bladder scan, and or they're in severe pain. Obviously, severe abdominal pain can be due to many things. If it's severe suprapubic pain, they've got over 500 mils on bladder scan, pop a catheter in. From a urology perspective, just see if there's any difficulties documented in the past. Some people are really difficult to catheterize, and that's known. They need guide wires to put in a catheter. And so that means that you're not going to do it yourself as the F1, you're going to ring the urology SHO or the urology registrar to help you out with that. Document the output once your catheter's in. And if you've got a urology rotation, I definitely recommend just learning how to do other types of catheters rather than this just standard sort of 16-14 French. Learn how to change a suprapubic catheter, learn how to put in a 3-way catheter. These are really useful transferable skills, even if you don't want to be a surgeon. Other things you might be doing, NG and Riles tubes. Often the nurses are really good at doing these on surgical wards, so you may not be asked to do them as often. Removing drains, doing PICC line sampling, and a bit of practical theatre experience, of course. Okay, so we'll just finish off in the last few minutes with some emergencies. So we might just go over a few minutes. I hope that's all right with everyone. Sorry. So we've got a 63-year-old man who's day 4 post right hemicolectomy with an ileocolic anastomosis for a cecal tumour. So they've taken out a bit of his right colon, they've joined up the ileum to the rest of the colon for this tumour. You're asked to see him because he's got a temperature of 38.5. Now, we know our questions to ask over the phone. To be honest, you guys have come up with them already brilliantly. There are other obs. Blood pressure's low. The heart rate's really high, to be honest. Their resps are up and their SATs are on the low side. They're in severe abdominal pain. They're feeling nauseous. They're having rigors, and the nurse is worried. They don't look well. They think they need an immediate review. So on your A to E approach, things are fine from an A and B perspective, but by the time you've got down to C, you realise they are shocked peripherally. They are alert and orientated, but they're clammy, the abdomen is really, really tender in the right iliac fossa, and they're guarding. So what do we think might be going on with this patient? Yeah, absolutely. Brilliant. Anastomotic leak. Absolutely. They're septic. They've got an anastomotic leak. So I'm not going to test you on your sepsis 6 here, but you're going to do your sepsis 6 essentially. All of those things that are really very much drilled into you at medical school, it actually does work and it helps. And you're also going to get them a senior review because you think this is an anastomotic leak. And that's what you're going to say to the reg over the phone. And that will get them definitely to come and review this patient. So an anastomotic leak is a leak of luminal contents from a surgical joint, and you get this worsening abdominal pain and septic picture. As I've said, escalate immediately to a surgeon if there's any suspicion whatsoever, and they'll usually need a CT scan. So make sure they've got a cannula in for not just fluids and pain relief and antiemetics, but also for contrast. They'll need usually a pink cannula in for that. And they may also need to go to theatres. So some of them are managed conservatively, but some of them will go to theatres. So keep them null by mouth from the point that you've reviewed them. Fab. Next emergency that I'll go through is an acute upper GI bleed. It's something that people worry about a lot when they start F1. It's something that happened in my 2nd month of being an F1. But once you've managed it and you realise that actually people will come and help you, it's an emergency, people will come, you'll feel a lot better, like if that is reassuring to you in any way. So initial management, big thing, just call for help. You need help immediately. Do your A to E approach, get some IV access and some bloods, the bloods that you need, generally an FBC, use the knees, some LFTs, clotting, and a group and save, or well, a group and cross match really is. If they're bleeding a lot, just put out the major hemorrhage protocol, and keep them nice and warm because they're losing blood. They're going to get cold quite fast. And for an upper GI bleed, you can then start thinking, once you've done the first bit, about calculating your scores for endoscopy. Management tends to be endoscopic or embolization, but they're likely to have to go through a procedure of some kind. And that initial management, those first few points, that applies to all massive bleeds, for example, a PR bleed as well. These are just some causes of an upper GI bleed. So esophageal varices, a Mallory Weiss tear, and this little guy is H. pylori, causing some gastric ulcers that might perforate. Fab. So in the last few minutes, I'm just going to whiz through a few slides on opiate toxicity. So I'll just pop these up. So obviously multi-systemic signs and symptoms, most well-known pinpoint pupils and a low respiratory rate. The first thing you do, again, just call for help, do your A to E assessment and review the drug chart. How much have they had? And the mainstay of management will be ventilatory support, so bag valve mask ventilation if they've got an inadequate respiratory rate, and have just a low threshold to put out a medical emergency call at this point, because what you really need is an anaesthetist who can help you with the airway should that become compromised. And then the other part of management is naloxone. So give 400 micrograms once the airway is secure, and that can be repeated every few minutes until they've got a resp rate that's sufficient. That can be given via various routes, and you just really do need some anesthetic support here because the half-life of naloxone is really short, and they're likely to have a rebound effect where their resp rate will drop and their GCS will drop as well. Fab. So almost at the end, I thought I'd finish up with just a few top tips. My biggest tip to you all is just never ever be afraid to escalate a sick patient early on to your reg. they'd rather know about it. Surgeons have literally taken this patient into theatres and operated on them themselves. They want to know if they get sick on the ward afterwards. So just don't be afraid. Pick up the phone and call. It just literally won't do any harm, and it will do a lot of good a lot of the time. It's important to be organised on a surgical job. Your jobs list is your friend. Your little bit of paper, hang on to it for dear life. It'll save you a lot of bother. And I used to have a list of key phone and bleep numbers to hand on my phone saved for my night shifts. So people like how to call anaesthetics, how to call radiology, micro, and my seniors' numbers as well. Something that I know a lot of you worry about is that your seniors might be in theatre overnight. It was definitely something that I was worried about. But from experience, just think who else can help. Just think outside the box. If you're really struggling, your SHO and Reg are caught up in theatres and they can't come out and help you, you've got a hospital full of people who can. So think about calling your medical registrar who's going to be around on the wards. Call anaesthetics and ITU if you've got a sick patient. And if you've got a really sick patient you're really worried about, putting out a medical emergency call is no bad thing. You'll get help really fast and no one will tell you off for putting out a crash call. When it's not needed, they will if it's the other way around, I guess. Theatres wise, try and get in when you can, plan ahead and keep your colleagues in the loop about what you're doing. And from a well-being side of things, surgery is earlier start times and longer shifts. So just look after yourselves, everyone, and just prioritise sleep, exercise, eating some good food, and especially on your long days. That's really important. And finally, just enjoy it. My first surgical job was possibly actually my favourite job so far. There was just a great team environment. I had great seniors and there were 12 F1s. So it was really social after moving to a new city, just good for like making friends and from a social perspective. And from a medical perspective, it's really rewarding to see patients who come in unwell with appendicitis. You take out their appendix and a few days later they go home really well. So really high reward in seeing all of that. And there's definitely something to learn from every shift, just whether you want to be a surgeon or not. Just pick up the skills as you go on assessing unwell patients, doing some practical procedures and getting into theatres. So I hope that was helpful for you all. Sorry, I'm so sorry for running over for about 5 minutes or so. Are there any questions at all? Just pop them in the chat. You can unmute. I hope you can unmute on Medal. I'm not too sure. And I'm just going to put in the feedback form into the chat as well. So yeah, I'd really, really appreciate it if you could fill out that feedback form. It would be really useful. Thanks so much. You guys have been great in the chat as well. Thanks very much for your participation. Yeah, here's a few little references as well. I think you'll have access to all these slides afterwards. So yeah, if there's no questions at all in there, I will just end the meeting now. But yeah, if you could fill out the feedback form, that would be great. And yeah, I hope you enjoyed. I think the feedback form also gets emailed to you afterwards. So I'll just hang around for about a minute longer, just in case anyone's got any questions, burning questions at all. And then I'll just end the meeting after that. Thanks so much, guys.